Mindie is a professor of medicine at Stanford. She's essentially the director of all hepatology education, and that includes their hepatology fellowship and their clerkship. Mindie did much of her training in Southern California at UCSD and then finished her training at Stanford, where she is now. It's always interesting to read over someone's CV as you're preparing to introduce them. Mindie's work spans all of hepatology. We know her best, or I know her best, for her work and her real international expertise in hepatitis B, but she really has interests and expertise across the spectrum of liver disease and liver transplantation. And then something that caught my attention was that she has mentored over 130 trainees, continues to mentor people, including people that I work with at CPMC. So Mindie is an incredibly valuable resource, not just for academic hepatology, but also for training in Northern California. And we're very privileged to have her here to talk about updates in hepatitis B. Thank you, Mindie.
Good morning. Thanks, Will, for the very kind introduction. I first would like to thank the organizers of this meeting to invite me. It's always a pleasure to be here and get to connect with many of the colleagues from my home community. And this year, I'm very glad to only talk about hepatitis B, because usually I'm asked to talk about both Hep B and Hep C, and that's very difficult to do in 20, 30 minutes for the whole year kind of updates. So this year, Dr. Hunt asked me to start with a case study, and I think this is a really great idea, and this is actually how I would like to start many of my talks when I give talks. So we will start with what is current and updates for 2018 standard and with the current therapies, and then a glimpse into the future. What is our progress toward HBV cure? We already have DAA for Hep C, how about Hep B? We don't want to be left behind. And Hep D, which is kind of something come with Hep B, isn't anything new. So I will credit this case to Dr. Will Hunt. He gave me this case. So 39-year-old man, native of Vietnam, referred to you for initial evaluation of chronic Hep B. So quite common scenario for many of us in GI and hepatology in this area. And you determined that his infection is chronic, likely vertically acquired. We'll talk about that in a little bit. And he has comorbid overweight, BMI of 26.8. and hypertension and no diabetes. Uncle died of liver problems. He's not very sure, but he's unaware of any other family history of either chronic Hep B or HCC. But as typical for many immigrants from developing countries, his father died in his 40s or so during the war. He is the eldest brother, so he only has 2 younger sisters. And the reason I mention that is something that we'll refer to later. Evaluation done that he came with. So luckily he had DNA, 70,000, e antigen negative and e antigen body positive. And we take this for granted, but our studies in the include Stanford and PAMF and several private GI practices, found that actually only about 70% of the patient, even after evaluations at a GI practice, would have an e antigen serology or DNA. And this doesn't mean that the GI doctor didn't order, but it could be that but the patient didn't do it. But then at the end, you know, if it's important, it's something that we could also try to recall the patients. I mentioned that to let us know that even simple things like that could be improved and it could be helped by both patients and doctors. AST is 30, ALT 41, platelet 190,000, ultrasound, smooth liver, increased echogenicity, maybe from fat, maybe some from liver inflammation, not clear, maybe fat. Spleen is not large, 10.4 centimeter, fibroscan with a cap of 260 and LSM of 6.8. Okay, we're gonna go back to all of these details in a little bit. So the typical questions that the patients would want when they come to see us, and therefore that is also what we should address and think about, is what anything else that needs to be done, and what's the prognosis? Am I going to die in 5 years, 10 years, or 30 years? What's the chance of any of that? And what we recommend to the patient in regards to treatment. So patient want to know, do I need treatment or not? And especially in the Bay Area, people spend a lot of time on the internet and see all kinds of things, so they will and ask us, I heard on these new therapies, am I going to be able to get it next year or in 5 years? So these are things that we need to look down the road a little bit. Clinical epi is my dear topic. I will only have 2 slides on this, I promise. So this is an updated modeling study that estimates prevalence for the whole world. And as you can see here, usually red is bad. So you can see here, most of the world is red. And the only green is basically North America, Western Europe, parts of South America, and Australia. So basically, most patients who come from anywhere in the world besides those green area, they have a prevalence of 2% or higher. That means that they should be screened. We don't even need to ask any more questions. It's like the Hep B birth cohort with, Hep C birth cohort with that we just screened. We don't have to ask for more risk factors. We just screen them. And evidence show that the screening is really suboptimal. So we can all do more with this. The primary care doctor is our front line, but many patients also show up to our GI clinics with dyspepsia, colon cancer screening. So those can give us opportunities to also offer some of these screening. And then coupled to that, from these large real-world studies from the U.S., from experience about 50 million U.S. persons here and about 44,000 Hep B patients, we found that the Hep B patients who are already chronically infected are getting older and having more comorbidities. So all of these together really should remind us to screen the patient, manage them, and prevent complications before they get older, before things get more complicated. And I think that this is just a quick review. I think that this audience is very well knowledge with this. So mainly we'll focus today on the group that are infected here with positive surface antigen. Sometimes we also should be mindful and would see patients who are at risk for reactivation, the last one there, and also the second line, people who are positive for anti-core, and whether surface antibody positive or negative, they could still be at risk for reactivation. And nowadays, with so much immunosuppression from biologics in IBD clinics, in rheumatology clinics, we really have to pay attention to this. It's not the usual chemotherapy patients who come see us for cancer. And that I think that we have been, our radar has been on, but now our radar has to be even more because some of these new biologics, like the rituximab, for example, is even worse in terms of reactivation in some cases. So evaluation for infected patients, this patient already got many things, so that's great. E-antigen serology, DNA PCR, the usual liver enzymes, and then liver function. So when we work with primary care clinics, I always try to separate the enzyme AST and ALT, so markers of inflammation. Specifically for function is INR, bilirubin, albumin. Also renal function for many things. As I alluded to earlier, patients are getting older. Many of them have comorbidities. And if we treat the patients with some antiviral, then we do need to know liver function so we can adjust the dosage. The fibrosis, portal hypertension, CBC, fibroscan like this patient had. And last but not least at all, very important is ACC screening, ultrasound alpha-fetoprotein. So generally, lab tests and liver ultrasound every 6 months, and things that we only do once at baseline is check for Hep A immunity and co-infection with Hep C, Hep D, and also HIV in most cases. Okay, let's go back to our case. So this patient is a man. That's an important thing to know because, as you know, men is about 2 to 4 times higher risk of disease progression, cancer especially, than women. Sometimes I joke with the patients, this is one of the few things, it's a disease. Usually many diseases are more common in women, but for this one, being man is worse. 39 is sort of borderline. I think that's why Dr. Hong chose this case. Many things are a little bit borderline, and this is what we see, the gray zone. The patients from Vietnam, the prevalence in Vietnam is 6 to 10% depending on the age. So definitely this patient should be screened, and looks like he has been screened, so that's great. And likely vertically acquired. Now, this is most likely true, but something that we should also remember is that a lot of the patients, 20 to 30% of people from endemic area actually have horizontally acquired infection in early childhood before 5 years old. So they still also have had the infection for a long, long time. So as you know, when someone is exposed to hepatitis B, at birth or younger than 5 years old, then more than 90% will remain chronically infected. Now, the adults who get exposed to hepatitis B from blood transfusion or drug use or sexual exposure, they tend to clear the infection more than 90% of the time. So that's why the chronic patients that we see are usually the patients who get the infection at very early childhood or neonatally. E negative, and then DNA 70,000. So the cutoff, I will show you in a little bit, is usually about 2,000 to 20,000 for treatment indication. So this is clearly in that range. The tricky part here is the ALT of 41. So we're going to talk about the cutoff for ALT in a little bit. So depending on who you read, this person would meet treatment criteria fair and square right now. Regarding the ALT cutoff, and we'll go through this in just a little bit. So stay tuned. Platelet is 190, so this patient does not have obvious signs of portal hypertension on exam or by blood test here. Ultrasound is not so remarkable. Fibroscan. So the CAP score is to estimate the amount of steatosis in the liver. So this person is also right at the near the borderline, just right underneath the cutoff here for 11 to 33%. So this patient have at least mild hepatic steatosis. And then for fibrosis is the LSM there. So this person, according to the score, doesn't have F2 or higher. So in summary, this is, I would summarize this man as a 30-year-old man, native of Vietnam, E antigen negative with moderately elevated HBV DNA, with mildly elevated ALT, no obvious signs of advanced liver disease, with probably fatty liver, and he doesn't drink alcohol that we know of, so that's probably non-alcoholic, and no advanced fibrosis on the fibroscan here. Now, what is the accuracy rate for fibroscan? We probably all know that it's not 100%. It's not 90%. It's in the low 70%, depending on who you read, but it's around that. In fact, it's actually not better than if you just order the FIB-4 test. People with fibroscan probably don't like me to say that, but the fact is that, you know, it's easy. You just do it and you get a number. Whereas the FIB-4 and all these non-invasive scores, we have to find 3-4 different lab tests and plug it in. So we are all clinic. So we don't tend to do that as much, and fibroscan or just ordering a fibro test seem to be faster. But actually, accuracy rate is not any better. There are very large meta-analysis that, you know, due to time, I'm not showing you the results here, show that the FIB-4 test is actually fairly equivalent to the fibroscan or elastography results for both Hep B separately and Hep C separately. So first question, what additional tests should we order? So the liver function, and this is something that people tend to forget. Usually everyone get an AST and ALT, it's in the panel, even healthy patients get it. But, and T-bilin albumin is usually in the liver panel, but INR not always. So usually I just check once baseline, you know, unless they are cirrhotic, we don't need to check it again and again. Creatinine baseline, liver cancer surveillance. So currently the guidelines say ultrasound and consider AFP. I have always done ultrasound and AFP together. I find that it informs each other. And check Hep A for total antibody. If the patient is not immune, then we vaccinate them and check for co-infection. And then now the next two questions is harder. The next two questions is what's the level of risk and the need for therapy now or not. So with this, I would like to go to a brief review of natural history and the current therapies and the current treatment goals. So we all probably tell our patients in one way or another this diagram here. And so usually I would bring a fellow in so they can observe how I would tell the patients. And basically we have to tell the patient this in a way that the patient will understand in 1 minute, because we usually don't have a lot of time in the clinic. So basically I usually tell the patients about 20–30% will end up with cirrhosis or liver cancer, and that can cause premature death. And one thing that I always try to remind the patients as well as colleagues is that unlike hepatitis C and many other chronic liver diseases, hepatitis B can cause liver cancer without cirrhosis first. So Hep C is very rare to have cancer without cirrhosis, but in Hep B cases, 20–30% of the Hep B cancer occur without presence of cirrhosis. So currently, the goal of treatment is these surrogate markers. So at the end of the day, what patients care about and what we care about is to prevent early death. And that is due to cirrhosis, liver cancer, liver failure. But that takes many years. So our surrogate markers now is virologic response, a reduction in hepatitis B DNA, and if you have tissue, it's in cccDNA, because if you eliminate that, then the patient is cured. But of course, we don't get liver tissues to just look at that, so I just listed in there, but that's not something that we measure. Histologic improvement, the same. Only in clinical trials that they would get serial biopsy, but in real life we don't do that. But in fact, we just go to the biochemical liver test here. We look for improvement in AST and ALT, bilirubin, INR, albumin, and we have very good data to show that the current therapies are excellent in suppressing the virus DNA and also in normalizing AST and ALT and improving the hepatic function. So we have excellent long-term data for this now. And in the other side, histologic improvement, we also have clinical trial data to show that these blood tests measurements correlate with histologic improvement in the vast majority of the patients who had serial biopsies, and then serologic response. So this is something we look for, okay? And I'm going to spend next several minutes on this, because in E-positive patients, we tend to use E antigen loss and seroconversion as something quote-unquote durable to stop the patient from stop therapy after maybe 6 to 12 months of consolidation period. And if we read textbook, they would say that, but in real life, actually, I would tell you that, in real-world studies and in my experience, the majority of these patients will relapse even after 1 year. So as a rule, I don't stop after each of these and usually discuss with the patients. Some will elect to just remain on it, and some will stop, but we have to monitor them carefully. And some of these data come from Taiwan, because in Taiwan, because of the limited resources, the government only paid for 2 years of medication. So after that, they would have to stop unless the patients are willing to pay out of their pocket. So they have this natural kind of, history, semi-natural, a patient getting off. And it really clearly shows that a lot of people will relapse, except a small proportions of the patient may have durable response. And there are a lot of research to try to identify which one are going to be durable, which one will relapse, but the majority will relapse anyway. And then surface antigen loss and seroconversion. So this is like the gold standard for the treatment now. So what we call functional cure. So in these patients, DNA will be undetectable, surface antigen will be negative, and surface antibody may be positive, hopefully, or maybe negative. So these are the patients that we consider to have functional cure. They're not truly cured, because the cccDNA is probably still there. So that would be complete cure, and we're going to go through this again in a little bit. So functional cure is what we would hope for, and after that, it's usually durable. The risk of liver cancer and everything is much lower, and case reports suggest that patients who get cured like this. After 40, some of them can still develop liver cancer, and I still monitor them, but younger patients are usually fine. So this is really the gold medal that we all want. But is it really possible? How often does it occur? So this is what I would like to review with you and show some of the updated data, and this will set the stage for us to see why all of these excitement and like more than 100 compounds going on to try to get this cure rate higher. So this is a study that we presented here in San Francisco a few weeks ago. So these are untreated patients. This is a large cohort of more than 10,000 patients from several sites in North America and Asia Pacific, including Taiwan, Japan, Hong Kong, Korea, etc., that we collaborated with. So in this study with long-term follow-up here, the spontaneous clearance per year rate is 1.33%. And you can see also in the graph here that after about 20 years, this rate go up to about 25%. So in this one, it showed that it's about 1% per year or so. So it's possible, but it's low. So I tell the patient it's not completely hopeless, but just don't wait for it because it's quite rare. How about treated patients? Are we getting this rate higher in our treated patients? So this is a recent meta-analysis that we performed. And in this study, we included both treated and untreated patients. And we can see that the annual clearance rate is also just about 1.1% or so. So it's not really better. And in sub-analysis of treated, untreated, they're similar, actually. And in some subgroup, the treated patients even lower. So why is that? Actually, we wrestle with this, and we reanalyze and check data, everything many, many times again. And it's because the treated patients started out sicker. So with these predictors show that less sick patients who start out with lower DNA, with lower quantitative surface antigen, would be more likely to clear, which makes sense, right? And our treated patients started out with much higher DNA, with more fibrosis, etc. So, and we don't treat the people who are not active disease. So therefore, the current data from meta-analysis show that the rate in treated and untreated patients are similar. And that's not because the medication doesn't do anything, but it's because on the treated patients, we start out with sicker patients. So maybe we have reduced it, but still not great. So for now, the treatment goal is really long-term viral suppression. So we have to be content with that for now. But there are several agents under investigation now to induce higher rates of functional cure in clinical trials in phase 1, phase 2, and some are still preclinical studies. And we're going to review a few of these just to kind of see what's in the horizon. And now I want to show you this, and this is really one of the slides that one of my least favorite slides to show in any lecture, because I think it's just too many things, too much. And in some ways, I feel like our field could have made things simpler. It's just, we cannot even agree, as you can see. All of these are major national or regional society guidelines or guidance, and there are a lot of differences here. So let's start with E negative first. So for E negative, fortunately, the cutoff is 2,000, and it seems like most people agree on that. For E positive, it's either 2,000 to 20,000, depending on who you read. But ALT is most difficult, is the trickiest area here. So what is a normal ALT? So this is an own topic, but it doesn't go away. So typically, we probably think that normal ALT is what the reference range in the lab that we get, lab report that we get, say. And this can range anywhere from around 30, 40 to even 60. So I can tell you that at Stanford, in the last 10 years or so that I've been there, the upper normal ALT listed in our reference range has ranged anywhere from 30-something to at one point like 66 or something. So when it was as high as that, I just could not bear it. So I studied it, and I looked into it, and I eventually got to the chemist who set this reference range for us. And I found out something that was quite interesting and revealing. So how do they set this reference range? So all reference labs are required by the FDA or whichever regulatory body. Every time they use a new assay, they have to test like 150 people or 100 people, something like that, that they consider quote-unquote normal, and get the middle 90, 95% to be the normal range. And then, so that sounds reasonable enough. Then I asked them, how do you find the normal patients? So they just went to a community health plan in an affluent area in Palo Alto, and they just randomly pick 150 patients, and then they just test those. So those patients can come from GI clinics. Those patients can come from heart failure clinics, right? So these reference range of normal populations are not truly normal. And usually when you go to Quest or LabCorp, I think that their range is a little bit smaller, because I think they must test their national lab, so they probably test a bigger sample. So, and then there, even one time I asked him, so why now 66? Then, you know, sometimes people really complain that if they lower too much, then too many people with abnormal liver tests requiring evaluation. So they even at one point increased it to 99% confidence interval. So I just wanted to share that so that you can keep it in mind that sometimes, I'm not saying that this is a requirement. Some place maybe do more than that to determine their reference range, but the requirement for a lab to set their reference range is actually not very high. So the reference range printed out on the report may or may not be the true normal range for truly healthy people. We have good data from Italy many years ago in that truly normal people, ALT is 19 cutoff for women and 30 for men is the true normal healthy patients. And that have been replicated in many other cohorts around the world, both in Asia and non-Asia area. Okay, so getting back to ALT here. So whatever ALT cutoff is used for E positive for each of these guidelines, is the same for E negative. So we can just focus on that second column there. And I highlight the red because AASLD is our liver society in America, and the other one's an expert panel in the US, so these are US based. So I highlight that. For the US algorithm, we will have an update early next year. So ALT, so the European Society just picked 40 as normal for both men and women. And then for the US algorithm, we picked 30 and 19 according to that landmark study from Italy, and any elevation would be an indication for treatment. The AASLD used 2 times upper limit of normal. So before the 2018 update, the AASLD also used the 30 and 19 cutoff based on that study, and then for the new one, it's raised a little bit to 35 and 25 for men and women respectively, and 2 times of that. So that's why I calculated it to be 70 and 50. And for all of these guidelines, significant fibrosis, F2 or higher would be an indication too. And Asia Pacific has a higher threshold. Some of this is due to their limited resources. Okay, so let's go back. So let's focus on the AASLD guideline at the bottom there. Okay, so this is our, our official liver society guidelines. So 20,000 E positive, E negative is 2,000. Our patient is E negative and 70,000. So this patient would meet treatment criteria by DNA standard, but by ALT standard, he doesn't meet it because he's only 41 and not 70 or above. But he would meet the criteria for the US algorithm there, and he doesn't have significant fibrosis according to one single fibroscan. And I want to emphasize that the accuracy rate is only about 80% range, okay? So I don't think we should make a lifelong decision for a patient based on a single test, a single imperfect test especially. Okay, so, also a study that we presented a few weeks ago at AASLD. So these are about more than 6,000 patients here, coming not just from Stanford clinics, about 800 patients, but also from several community clinics in the San Francisco Bay Area, from several primary care, 4 primary care clinics in San Francisco, primary care clinics in the Palo Alto area, and some community GI practices, about 1,700 patients, and also the well-known review cohort from Taiwan. So these are truly community-based patients, not a clinical cohort, about 3,500. So this is a cohort about more than 6,000 patients, and median follow-up is 8.61 years. So these are the patients who were treatment naive, and they did not meet, doesn't fall into any criteria of active patients or inactive patients according to the AASLD definition. So what we found is that even after long-term follow-up and serial measurements of blood tests, etc., we have still a big gray zone. So as expected, that you have more inactive patients, the green bar, among the community patients from Taiwan, and more in the community clinics in the US, in this area, and the smallest from university clinics. But out of this, you can see the gray zone range at least about 1/3 to 1/2 here, indeterminate. So even if we are dutiful and the patient is good, keep coming up and follow up with us, even on long-term follow-up, there are many patients that are still in the gray zone. So with follow-up, we can recategorize some of these patients, but still a very large group of patients that what are we going to do? We can read and know all the guidelines, but so if we stick with one guideline, for example, then we don't know what to do with these patients. Now, does it matter if they're in the gray zone? If they are increased risk, then why should we care, right? But we should care because they do have more cancer than the inactive patients. So the blue arrow will show you the line of HCC incidence in inactive patients on long-term follow-up. It's pretty flat, so that's good. So the definition for inactive patient is good. But look at the bar there with the red arrow. So that is the indeterminate patients. Okay, so the highest line, so the highest HCC risk is the patient categorized to be active disease and not treated. So you can see that even in these practices, some patients are not treated, but a lot of these are from the Taiwan community cohort. So they active disease, not treated, they are the worst off patients. So nobody argue about that. So if you treat those patients, and then they get lower, and their risk is in those dotted line there. So it looks like the indeterminate patients here seem to have similar risk, according to this, as an active patient who get treated, but still much higher than the inactive patients. So this data doesn't show us if we treat these indeterminate, would they be better off? We don't know that at this point because there are not enough of these people get treated. Some are, but not enough for us to analyze it at this point. But it's something that we're looking into further. But the point I would like to make here is that even though we do our best, not clearly define many of our patients. So a lot are in the gray zone like our patients here. And one thing to remember is that they are not safe. So tell the patients in his risk. So I definitely would tell him that you have. The risk of cancer. So I would tell the patient that he has no cirrhosis that we know of, so his risk is about 0.2 to 1% per year. So generally 0.2 for men, for women is much lower than that, and it reaches about 1% per year after about 50, 55 years old or so. And I find it better to give patient a number because it's something people can quantify. And I would tell the patient, you're only 40 years old, so even though it's only 0.2 or 1%, after 20 years, that can be 10, 20%. So that's significant. The risk of progression to cirrhosis is harder to quantify. We don't know we don't have as good of data for this because cirrhosis is much harder to diagnose than ACC. And I would tell the patient that his indication for antiviral at this time is borderline according to at least one treatment guidelines, and he may meet criteria for another guideline. So what I would do in this patient personally is that I would monitor him. I would see how he declares himself, give him some time to see which way he's going to go. And I would tell him that he need to get alpha-fetoprotein liver ultrasound every 6 months because of the cancer risk. And without doing this, there's almost no chance to diagnose the disease at a curable stage. And I probably would do fibroscan in about a year or so, or yearly. And I generally don't believe a fibroscan after one time because the accuracy rate is in the low 70%. That's not good enough. So I tend to feel more comfortable if they have had serial tests a few times that say the same thing. And as alluded to earlier, many patients are indeterminate phenotype, gray zone, and they are not exactly safe. So we need to still continue to learn. There's a lot more we don't know, and we need to further investigate. So there's an abstract that show results on study of children. So this is important, maybe less important in the US because this is not so common, but in other countries, yes. So down to 2 years old here. So this study is tenofovir, and it shows that it works very well. The children respond after 1 year, even in E-positive patient, about 80% of them would have viral suppression. So it works, and this is not something unexpected. It works well in children. What we worry the most is probably the safety in children. So in this, it seems that it's also safe, except that the increases in the bone density seem to be smaller than in the TDF patient than the placebo patients. Now, how about the cure frontier here? Okay, so as alluded to earlier, we want functional cure so that we can have a finite treatment duration, and then after that we can stop treatment, and then the DNA and the surface antigen will be negative and stay negative, okay? Because currently, if we stop treatment, things will bounce back, or it never really clear surface antigen here. So if we achieve this, then we can stop therapy with minimal risk of reactivation if the surface antibody comes up. But the cccDNA is still there, and it's only under control because of the host immunity. So if the patient is immune suppressed by disease or by medications, then the patient will be at risk for reactivation. So this, I think, is good enough in most cases, and this is what the current cure effort is targeting. The dream, and maybe in the distant future goal, is complete cure, and some people feel that this may never be possible. Dr. Harry Greenberg at Stanford, one of the pioneers in using interferon for hepatitis B, would say that, you know, it's impossible. Once you have Hep B, that's it, you know, you have it. But this is what people mean by complete cure, is clearing, eradicating the cccDNA. So if this occurs, then the patient would no longer be at risk for reactivation either. So of course, you know, this would be a better goal. But I think that for now, the functional cure goal is good enough for the very vast majority of patients. So these busy slides are shown just not to really focus on any details, but this to just show you the complex life cycles of hepatitis B, from entry to secretion and everything else in between here. Currently, our therapy is only targeting this one, the DNA polymerase, and the current nucleoside and nucleotide analogs inhibit this DNA polymerase inhibitors, enzyme here, and we inhibit the replication of hepatitis B DNA. So right now, the current cure efforts includes both direct-acting antivirals as well as host-targeting therapy. So these are more immune modulators. They can be therapeutic vaccines, or it could be immune enhancing kind of medications. So this is there's a very recent review and very good. So if any of you are interested in learning this in more details, this is on Gastro, and it's been EPUB since September. So it's very comprehensive, and I just did a screenshot of one table here. So there are two tables, and each table is like, 2 pages. So this is only 1/5 of the list of the medications under development right now. So it just tells you that it's an extremely active, busy field. Most of these will probably never make it to phase 3 or market. But the effort is very, very active, and hopefully we'll have something in the future. It's probably not next year, it's not 2019 or maybe even after, but hopefully in the next few years we may see something. Capsid inhibitor is one of the more common targets here, and I will review a few of those compounds. But basically they are all still fairly early. So this is one compound, and it shows here very nice reduction at this dose, and it's fairly well tolerated. And this is a capsid inhibitor. And then this one is by Janssen. And also, again, you could see, that very good efficacy here, and so far fairly well tolerated. So basically, as with new drug developments, efficacy is important, but a lot of time what kills the drugs is the toxicity, especially for hepatitis B. So that's something that, we really need to keep in mind. It's not like cancer, that they're going to die if they have no treatment, and if there's if they have no other option, they're going to die. Whereas Hep B, the patient's asymptomatic, and 70–80% of them will never die of hepatitis B. So that's why the bar for clinical trials and safety for Hep B medications should be much higher, and currently it is high because of that reason. And meanwhile, we have a pretty reasonable option, the nukes, that we can suppress the viral suppression. And this one is by Springbank, and this is an immune modulator. And again, it also shows very good promise. So I chose these 3 because these are, among the 3 that show some of the best data, and they also were chosen to be the best of AASLD. So actually, this is new this year for AASLD. I'm not sure it's new this year or maybe in the recent years, but it makes it very nice when we want to pick out something to show for an event like this. And hepatitis D, I think I showed this compound last year, so it is ongoing and continue to be very promising. So in our area here, Hep D is not so common, but there are some patients. But in some parts of the world, and this is a melting pot, so we may see those patients where Hep D is very common. The current therapy for Hep D, as you know, is terrible. Interferon, the response rate is very poor, and the side effect is very bad. So something like this is really ground for hepatitis D. So I would like to end with this summary that we have multiple emerging therapies for HBV cure and Hep D. So it's very positive, it's very promising, it's very noisy and crowded right now. Hopefully in the next 1 or 2 years, we can identify better the compounds that will probably be at the finish line. But meanwhile, we have very good existing options for our patients for long-term suppression, which has been shown by ample data that it can reduce mortality and liver cancer. So the top line is entecavir, tenofovir, and TAF, also interferon, but it's not, most of our patients are not great candidates for it. And one thing to also remember is that Hep B patients are now presenting older and with more comorbidities, so improved linkage to care is needed and always needed. And patients not meeting guideline criteria now for treatment may still be at risk for ACC, some of them, the ones who are not clearly inactive. So they should be monitored and they should be advised that they may need antiviral therapy sometime in the future. And I like to end with this because even though this is an own study and an own estimate, newer data that we are working on that not yet published is actually because we actually haven't done too much better from here 10 years later. So it remains very bad and much more needs to be done. And I think we can all chip in by doing it, screen the patients and address the problem whenever we could, whether the patients see us for Hep B or not. And with that, I would like to end. Thank you for your attention.